So I'm going to talk to you about anticholinergic burden, and to be honest with you, during the preparation for this presentation, it became apparent to me that my own practice needed to change a little bit. So I'm hoping you're going to take away a few messages from this talk. So I'm going to cover what it is, what the phenomenon is, what we should be concerned about, how it can adversely affect our patients, what we should be doing about it, and finally I'd like to talk about those difficult cases, so those patients who are incontinent and come to see us and they have dementia as well, and how we should be managing them. So what is it? Well, it's the cumulative effect of using multiple medications with anticholinergic properties all at the same time. And the problem is that it has an adverse impact for our patients on their cognition, on their physical function, and it also increases their risk of mortality. So why should we be worried about this? Well, there's been lots of media coverage about it recently, but essentially the World Health Organization tells us that the world's population of over 65s is going to double from 11% to 22% from the year 2000 to 2050. And so we're all going to get older, we're all going to need a few more medications to keep us going, something for our arthritis, something for our heart, and essentially, about 85% of 65 to 75-year-olds are going to be taking lots of medications, and 40% of those people are going to be on more than 5 medications. And this is what polypharmacy is. And with you all taking more than 5 medications, some of those will undoubtedly have anticholinergic side effects. So this is the list of anticholinergics that we're all used to, and we use in urology a great deal: antimuscarinics and tricyclic antidepressants. Not comprehensive list, but nevertheless, this is common knowledge to us all. But then we've got those prescriptions that our patients come in with, which may have hidden anticholinergic properties. And a lot of you will look at this list and said, well, I knew that. But, you know, there are lots of things such as over-the-counter antihistamine medications that surprisingly have quite significant anticholinergic properties. Then the ones in green, such as atropine, are drugs that are prescribed specifically for their anticholinergic properties, so for bradycardic emergencies. And then the ones in red are the ones that have side effects, anticholinergic side effects that are not specifically used for their properties, but happen to have anticholinergic effects as a side effect. So for the patient, what does this mean? Well, this means this list of adverse effects that we all know, but can you imagine if you had one of those effects, side effects, and you were suffering with those, it would really impact quite significantly on your quality of life and your day-to-day living. So there are various factors that can increase our risk of these effects. And firstly, it's the strength of the medication that we're taking, and I'll tackle that in a little while. It's the dose of the medication. It's the number of medications that have anticholinergic properties. And of course, as we age, our physiology changes. We may have renal failure, and that changes the way that we metabolize the anticholinergics. If we've got pre-existing disease, such as dementia, that is also an issue because of the cognitive side effects of these antimuscarinics and anticholinergics per se. And of course, as the population ages we get older, we are more sensitive to anticholinergic side effects. So the big soundbite about this, and I suppose why I'm talking about it today, is that recently, there's been a lot of media coverage about the effects of anticholinergics and their effects on cognition and the brain. And this is so much of a problem that in my clinics, I've certainly seen patients, younger patients, who've questioned my scripts and asked me questions which we didn't have 5 years ago about their risk of cognitive decline and dementia. And in America, it's such an enormous problem that the Federal Aviation Authority have actually banned all their pilots from flying and given them ground jobs and desk jobs if they're taking any medication, not just for their bladder, but any medication with any anticholinergic property. So I suppose the big paper came out in 2015 by Gray et al., and they looked at, it was a longitudinal population-based study, and they looked on the cumulative risk of developing dementia and Alzheimer's disease over 10 years. And what they did was very nicely standardize the daily doses and look at patients in various different groups of how long they've been taking these drugs, and found that the patients who'd been on the drugs for a length of time over 1,000 days had an adjusted hazard ratio of developing dementia of 1.54, which is significant, and also for Alzheimer's disease slightly higher, 1.63. So I'd like you all now to pause for thought. Would you take oxybutynin if you knew that it was going to increase your risk of dementia? And would the severity of your symptoms currently correlate with your decision to start this drug for yourself? And finally, do you discuss this with all your patients, anyone you're starting on anticholinergics? So I suppose when we're looking at the drugs, are they all the same? Well, I just want to remind you about a little bit pharmacology, but there are sort of 5 subtypes of muscarinic receptor, and the ones in the bladder that are the most important are the M3 receptor, which coordinate detrusor contraction. The ones for cognitive function that are most important are the M1 receptors, and those are mainly in the hippocampus but distributed all through the cerebrum. And darafenacin comes out rather well in this respect because it has an affinity ratio much greater for the M3 than the M1, 9.3 to 1. And trospium, which usually, most urologists think of as being very useful in the elderly, comes out quite badly. It comes out as well as oxybutynin, which is quite poor, at 1.5. So to clarify this a little, we need to look at that it's not only about which receptors these drugs stimulate or suppress, but it's also about the maintenance of the drug within the central nervous system. And drugs that passively diffuse in are going to stay in the CNS and possibly cause cognitive decline. The drugs that passively diffuse have got to be lipophilic, they've got to be neutral, and they've got to be small molecules. And this is where trospium comes into its own, because it's hydrophilic, it has polarity, and it's a large molecule, about 40 kilodaltons. So lots of studies have been done now on cognition and anticholinergics, and essentially through MRI and functional imaging, we found that anticholinergics, they lower glucose metabolism, particularly in the hippocampus. Those that are on them for a long time have got reduced brain volumes, larger ventricles, and they do worse in their memory tests performances, particularly mini mental test scores and also verbal reasoning. So another pause for thought, really. Anticholinergics increase your risk of incident dementia, so that is going to affect every single patient that we see with OAB and we're thinking of prescribing the anti-muscarinics for. If you've got dementia, it'll make you get worse faster, and that's going to affect all our patients we see with dementia and possible incontinence. It counteracts the dementia drugs, so lots of our patients who have dementia are on anticholinesterase inhibitors, and then if they have urinary incontinence and you're starting them on an anti-muscarinic, we've got to really think about what we're doing and whether we're counteracting the effects of one over the other and which is more important. They can cause delirium, and this will affect our acute admissions, and it could make that delirium get worse faster. So because of all this, there's been a great talk on anticholinergic burden and risk scales. And there are two methods, I suppose, of assessing the burden in our patients. Firstly, we can use rating scales, and secondly, we use radioreceptor assays. But practically speaking, radioreceptor assays are extremely difficult, not accessible, and on a practical level, in the clinical environment, rating scales are the best thing that we have. But there are so many of them, which scale is the best scale? And there are various reviews out there looking at all the possible rating scales. And the summary of the reviews really is that all the scales are pretty flawed. There's no uniformity. Lots of them describe a drug as having strong anticholinergic properties, and then you can find one where it only has moderate properties in another scale. But some of the most heavily cited ones are these, and it seems that the best one, the one that comes out best, is the anticholinergic cognitive burden scale. And I'll go through this in a little detail. But essentially, all the scales divide these drugs into, ratings of drugs with a 0 rating, either no anticholinergic properties at all or a weak property. Number one is one with a moderate anticholinergic property. Number two is strong, and number three is very strong. And the red arrows mark the ones that we use in neurology, so darafenazine, oxybutynin, tolterodine. They're all rating number 3. So if I can take you on to a little case study, a typical patient, 72-year-old man with Parkinson's disease, comes into your urology clinic complaining of urinary frequency and urgency, and how on earth do we manage them? So you've done all your usual assessments and decided, right, he has symptoms of overactive bladder, how should we treat this man? And you prescribe him tolterodine. That has a rating of 3. He's seen the neurologists, and they've given him something for his Parkinsonian tremor, and they've prescribed amantadine, which has a rating of 2. And the cardiologist has given him 2 drugs for AF, digoxin and warfarin. And his GP said, right, you have a bit of reflux, let's give you ranitidine, that's a rating of 1, and you're a bit depressed, let's give you amitriptyline, that's a rating of 3. So you can see how quickly this man has been piled up and has now got a burden of 11. So what studies tell us is that anything above a rating of 3, then the patient is 70% more likely to suffer with 2 anticholinergic side effects that are clinically relevant. So we found this study from Ealing Hospital, which it was published in Clinical Pharmacology in 2013, and this quite nicely tells us what we should do if a patient has a high score. So firstly, review the medications. Is it essential? Is the medication essential? Is there an alternative? And if there is no alternative and they're continuing on that, then we need to monitor our patients. So the mnemonic they use is MAP. And I find that quite useful to use when you're looking at patients who are on several drugs. So back to our man with Parkinson's disease. If he comes back to the clinic, I would hope to review the medication, maybe stop the tolterodine, maybe give him mirabegron, maybe ask the GP to stop the amitriptyline, and maybe the GP will consider something else. So that may bring his ACB score down now to 5, which isn't wonderful, but it is much better than a burden of 11. What does NICE tell us about this? Well, NICE says that before we start any overactive bladder drugs, we should be looking at what other meds the patient is on, and using some kind of burden scale to assess the load. Also, it tells us that we should counsel the patient as to the risk of the adverse effects, and this isn't the usual just dry mouth, dry eyes, constipation, dizziness, but really go into depth about what the possible risks of developing dementia could be. Studies that I mentioned before, the Gray study, in 2015, had a particularly nice point where they said that the risk of developing dementia is significantly increased if you're taking something like 5 milligrams of oxybutynin daily for 3 years. So there is evidence to suggest that 3 years is the cutoff. Then NICE says when we're choosing the overactive bladder drugs that we should be particularly careful and not prescribe oxybutynin to patients, particularly frail older women. But oxybutynin, tolterodine seem to be fine in the younger population, which I find quite bizarre. Darafenacin is mentioned there, but it's interesting. I don't know how many of you have got it on your hospital formulary, but we don't have it on ours, and even despite a recent review, because of its cost, it's been very, it just doesn't show up on ours, and we're a tertiary referral centre. NICE also say that once the patient's been started on these anti-muscarinics, we should continue to review the medications, and this should be at least a telephone consult or a face-to-face at 4 weeks to ask them about the adverse effects, and then yearly, but if they're elderly, every 6 months. So I'd like to come on to this problem, which, it's a really difficult case of the patient who comes in to see us and they are incontinent, but they also have dementia. How on earth do we manage these patients? And again, NICE gives us some guidance as to how we should be managing these patients. And Sheila mentioned this guidance earlier. There was an update in 2016, but it seems that incontinence is 3 times more common in people with dementia versus those without. We don't know how actually how prevalent it is. It seems to be about 1/3 of the patients. It's higher in care homes, and it's significantly a factor when patients are admitted to these care homes. So it is something to be concerned about. This is the NICE guidance, and essentially it tells us that we should be assessing all these patients on a case-by-case basis, and as we do with all our other patients, and we should try all possible relevant treatments before we decide that this is a permanent problem. So to help with this, there's a systematic review, and I'm sad to say that the conclusion was that there wasn't enough evidence to make any treatment recommendations at all. And then this patient has the added problem of possibly being on cholinesterase inhibitor drugs. And as I alluded to earlier, if they come into your clinic and they've been started on this drug recently with urinary incontinence, then I'd take a little time to pause there and just think about the reasons why they are incontinent. Could it be because they have been started on diazepam or some other drug that is relevant? This is a nice protocol for management from the International Consultation from Incontinence, and they say that goal setting with these patients is very important, and I would tend to agree with that, but particularly because the quality of life of the patient is affected, but also of their carer, which is often a close family member at home. And so it's really important to decide what the carer can do and what they can't do before you start the patient on a treatment cascade. And so obviously the gold standard is going to be independent incontinence for all these patients, but that's not always going to be possible. Some patients you're going to decide it's going to be okay if they have contained incontinence and they're using pads or appliances. Some patients will want to be dry with help, and the carer is going to assist them in their toileting behaviour. Some are going to be wet. But independent continence isn't always possible for each patient, and that's okay. But what's important is that you set the goals early out. So some key points about these drugs. Oxybutynin seems to be less effective for patients who have got impaired orientation and reduced bladder sensation. Tolterodine is also associated with cognitive impairment, and there are 2 studies which show faster decline in patients with dementia taking antimuscarinics and the anticholinesterase inhibitors. Mirabegron isn't mentioned, but it is an alternative in the NICE guidance for urinary incontinence. So again, if we pause for thought, what if it were you and you had dementia? What would matter to you more? Would it matter to you being continent or the fact that your cognition would decline faster, earlier, later on in your treatment pathway. It's a difficult one to answer, and I suppose you don't know until you're in that situation. So my final thoughts on anticholinergic burden. Medications with anticholinergic properties should be avoided in the elderly wherever possible. If they are deemed clinically necessary, then use MAP. Is the dose necessary? Use the lowest possible dose, the shortest duration, review your treatment, try and reduce the category 3s down to a category 1 or 0 drug. Warn your patients about the risk of incident dementia before starting their anticholinergic medications. And these are the patients who are cognitively normal when they come into your clinic. Explain to the patients and their carers who have pre-existing dementia that it may get worse and faster. Check that your incontinent patient with dementia hasn't recently been started on the anticholinesterase inhibitor, and that may be the cause for the problems. And set realistic continence goals for your patients with their dementia and include their carers. And thank you very much. I'd also like to thank Chris Harding, who was going to give this talk, but is going through a difficult time at the moment. So we're all thinking of him. And I'd also like to plug 2 courses. The Queen Square Uroneurology course, which is happening in October. Ask for some details if you're interested. And that's going to look at the approaches and management of bladder, bowel, and sexual dysfunction in the neurological patient. And also the Sacral Neuromodulation Masterclass at UCLH. Thank you very much.
Thank you very much. That gives us a lot to reflect on. Can I take any questions or comments? Yeah, please.
Hi, Mike. Great talk. You did touch very briefly on oxybutynin and children, which is an interesting area. Because
children?
Oxybutynin and use in children. Let me explain. It's still used for treatment of urinary incontinence in children. We know there is some evidence that the effect on anticholinergic burden is independent, temporary. In other words, you might have a difficult time in your 40s and beyond, have a high anticholinergic burden for 10 years, and that will hasten increase your chances of dementia later on in life. There's no evidence, as far as I know, but by suggestion, there may be concern that we're giving these drugs to children who potentially could be at risk of dementia later in life. Do you have any sense of that or any feeling of that?
Well,
how do we advise our patients?
Well, certainly from the studies, the systematic reviews that have been published, and there's been a lot on this recently, the suggestion is that if a patient takes anticholinergics for 3 consecutive years and then stops, and that's from the JAMA study, but then there's also the 3 Cities study from France that suggests 2 years might be the cutoff. So I suppose when we're counselling parents for our young patients who are starting on oxybutynin, we can use that data to guide us. But I'm sure that there's going to be a lot more work on this, particularly in the paediatric population.
Tamsin?
A couple of questions, really. Firstly, is this a kind of chicken and egg thing? I mean, are they presenting with precursor symptoms of their dementia and they're starting on anticholinergics and then they're developing dementia? How do they know it's the other way around?
Well, the big studies from the States, there's a big study on aging and Alzheimer's, and they look at, they've also looked at completely cognitively normal patients and compared the 2 groups. And the decline is apparent in patients who are cognitively normal.
And for the patient that's sitting in front of you in clinic, yeah, I'm a completely normal 53-year-old lady and I have problems. What's my absolute risk of developing dementia over 2 to 3 years? Because we put these people on them for life. Is this the death of anticholinergics?
Well, yes. The data suggests the hazard ratio is 1.54 of dementia, which is just the symptoms. Alzheimer's is the disease, but
What does that mean? You know, give me something I can say to the woman in front of me, because I'm not 53, Mrs. Venice, which is why I picked that age. But what's the actual, you know, what increased risk do I have? 20%, 50%, 100%?
well, it depends, I suppose, on your pre-existing risk. So if your risk is a 1%, say, it might be 1.54%.
See, that's not that exciting. That doesn't worry me as much as if you say
No,
it's quite difficult.
and it is very difficult, and there are no absolute figures, but then you can refer to the actual anatomical studies that suggest, you know, they have looked at patients and the differences in their brains, and they have, for what it means, you know, larger ventricles, reduced brain volumes. Do you go into that when you speak to your patients?
Gentleman at the back.
Yeah, how relevant is trospium, for example, to the anticholinergic burden if trospium simply can't cross the blood-brain barrier?
This is a difficult one. Trospium has a rating of 3, so across all the anticholinergic risk scales, it does have a high rating, but from its properties alone, it can't cross the barrier. But then with aging, we know that the barrier gets leakier. The patient has disease that may reduce vascularity. So although it physically shouldn't be able to get in, it does with an aging population. It can.
Jeremy?
Jerry.
Irene, thank you. You've talked a lot about side effects, but I don't really understand the efficacy. If you've got a cholinergic burden of 5, is there any advantage to giving them more anticholinergic? Because all the studies
Are you talking about the bladder? Or
yeah, for the
or
bladder,
what?
because all the studies on anticholinergics are on virgin populations, aren't they? But most of the patients we see are already got an anticholinergic burden on board. So is there any evidence?
I think this is where receptor specificity is important. So, you know, some are less M3 specific than others, and oxybutynin isn't particularly specific.
So for the example you gave with the patient who had this burden of 8, and then you add in another anticholinergic to take them up to 11, are you expecting to get any additional efficacy? No one knows.
Well, you'd have to look at each. I mean, I don't know the receptor specificity of amantadine or the others, but then you'd have to look at those.
Yeah. So I'm suggesting the next study we have to do is looking at patients' efficacy
Already.
on top of what
Yes.
they're already on, because that's most of patients.
Mm-hmm.
Take a final question from Sunny.
The other interesting group, the pediatric population, is obviously clinically very relevant. The other one that we're used to dealing with is neuropaths. And obviously anti-muscarinics are a massive treatment strategy for neuropaths. There's one thing managing symptoms, there's another thing keeping upper tracks safe and safety issues. So I'd be very interested actually to hear the opinions of people running spinal cord injury units, what their flavour, their take on this is in terms of anti-muscarinics. Because if that message is coming across and it is filtering across, what are we going to do for pediatrics and neurological patients?
John?
As somebody who manages a spinal injury unit, I'm going to choose to duck that question and instead thank our speakers. Thank you, Maureen. Thank you, Sheila. And thank you, Richard.
Thank you.
Thanks very much for attending. So that's the end of the update sessions. We'll see you all back at 1 o'clock after lunch. Thank you.